All right. So welcome everyone. We are now recording. I'm going to hand it off to Cameron and he's going to introduce us.
All right. Hello, everyone. My name is Cameron Robinson. I'm one of the AmeriCorps members with the LGBTQ plus Healthcare Consortium. Riley Craig, who is our other AmeriCorps member, will be helping me in the chat. I wanted to go over a few things before we get started. Just as a reminder, the session will be recorded, as Riley has already done, and later uploaded to our website. To protect all of attendees' identities, we will not be posting anything to show attendees or their names. We ask that all questions be put into the chat, and me or Riley will be reading them at the end of the presentation. If you feel compelled to give, we welcome donations to our Give Butter campaign. Donations will be given towards trainings we offer, like MedPath Mentors and future events. Please feel no obligation to peaceful no obligation, but if you would like to donate, visit our website and there will be a donate button in the middle of the homepage. One of us will be dropping the link in the chat. If you are receiving CEU credits for the webinar, that information will also be dropped in the chat. And I wanted us to give a big warm welcome to Brittany Deceased and Paul Kraus. Brittany Deceased is a licensed professional counselor at Health for Life Counseling in the Grand Rapids area. Brittany is a trauma-informed therapist. Her areas of expertise are domestic violence, sexual assault, abuse, neglect, relationship issues and relationship dynamics, sexuality, non-monogamy, and LGBTQ plus experiences. And then Paul Kraus is the clinical director of Health for Life Grand Rapids, home of the Trauma Informed Counseling Center of Grand Rapids. Paul's also a private practice psychotherapist, EMD, EMDRIA consultant in training, and host of the Intentional Clinician podcast, behavioral health consultant, clinical trainer, and counseling supervisor. Paul is the creator of the National Violence Prevention Hotline in progress, as well as the Intentional Clinician Training Program for counselors. Without further ado, I'm going to turn it over to Brittany and Paul.
Thank you, Cam.
Thank you, Cameron. And Riley, I'm going to share our screen and have Brittany kind of lead us along, and I'm going to follow in with comments.
Wonderful. So thank you everyone for joining us today on learning more about what is trauma-informed counseling. And I think a lot of us really want to know what is not trauma-informed counseling. As Cam introduced us, Paul and I are both trauma-informed therapists. If you could go to the next slide for me, please, Paul.
Absolutely.
I just wanted to re-highlight everything that Cam said about Paul being the clinical director of Health for Life Grand Rapids and the Trauma-Informed Counseling Center of Grand Rapids. I was really honored to, when I interviewed with them, that it hit all of my buttons on being trauma-informed, being focused on equity and inclusion. And I'm really honored to have been working with Paul now for 2.5 years. So if you have any questions about Paul or the Trauma-Informed Counseling Center of Grand Rapids or Health for Life, please feel free to ask those questions in the chat box or save them for later after we have this conversation today. And then we have me. Paul, do you want to talk about me at all?
Yes. Oh, goodness, it says my name at the top, but that's okay. I'm introducing Brittany right there.
It's me, Brittany.
It's Brittany. Brittany is amazing. She is brave, and she has a background in working with domestic violence, sexual assault, sexuality, relationships, LGBTQ community plus. And she came to us, and she had just got her license because she had been working in behavioral health a little bit before. And she has made a huge difference and really helped a lot of our clinicians who were learning about how to help the community more, even go further in their development, instead of just being culturally competent, working on being basically more than cultural mastery, like learning as much as they possibly could about the topic. And she has created 5 relationship programs for couples, including LGBTQ plus couples that are looking for a commitment, also ones who are just looking for maintenance in their relationships, also working with another therapist to develop a polyamory program for relationships and non-monogamy, non-monogamous relationship program, and of course, just some other basic relationship programs. So it's been a pleasure to work with her, and she's not afraid to talk about all the things, including the kink community and all of the things that a lot of therapists in Grand Rapids will avoid or stigmatize. Brittany is here for it, and we're so glad to have her. And now a lot of therapists are kind of following in her footsteps at our office as well, which is really cool to see, even ones who are not in the community themselves.
Thanks,
All
Paul.
right. Yeah, absolutely. So Brittany, I know you want to talk about what is trauma and what is trauma-informed treatment, what isn't it? So maybe we'll go a little bit here on the PowerPoint.
I thought it would be very beneficial for people to get a good example or definition of what trauma is. I think that there has been a lot of dialogue, especially on social media and TikTok, of people being hashtag triggered, but don't necessarily realize like what is trauma and how is it defined. So for those that need the definition read out loud, trauma results from an event, series of events, or a set of circumstances that is experienced by an individual as physically and or emotionally harmful or life-threatening, and that has a lasting adverse effect on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. So kind of putting it stately, putting it, I want to say simply, not stately, putting it simply is that it's something that has a reoccurring process in your body that is impacting you either mentally, physically, socially, emotionally, or spiritually, and that it doesn't always have to be one event, it can be several events. If you go to our next slide, Paul, I think it really clearly defines that in simple terms, that trauma can be understood as an extraordinarily stressful experience in life that has a lasting negative impact on someone. So some of those things that we talk about when we're talking about trauma-informed care include things like recognizing that environment, culture, and context of what has happened to them. So yes, we think of trauma as being war and domestic violence and famine and natural disasters, but we also know that people that are in marginalized communities who have had microaggressions, who have had racism, who have had other isms pointed to them can create trauma that is then going to impact them in all of those facets of life. So social, emotional, physical, mental, and spiritual. So Paul, I think in the next slide, we talk a little bit more about those ACEs studies, and I'm going to give that to you.
Sounds good, Brittany. And just before I get into the ACEs study, just to re-elaborate a little bit of what Brittany is saying is trauma is more or less in this understanding by the Substance Abuse and American Mental Health Services Administration here, SAMHSA. They have widened the definition from just post-traumatic stress disorder. And so that's important to understand. Obviously, people who have post-traumatic stress disorder have a very high degree of symptoms, but somebody who has trauma might also be experiencing depression, anxiety, chronic stress, worries and difficulties in relationships. And what Brittany said is it recognizes the environment and the culture, and we used to not do that. I mean, even as mental health, even 30, 40 years ago, context and culture were not really talked about as much. And now that we understand that growing up in a food desert without fresh groceries nearby could for some people be some type of trauma that makes them hoard food when they're older. You know, I mean, we don't want to, there's not just like one size fits all, right? And some people who go through difficult experience may not develop full on PTSD or trauma, but others might. So it is subjective. We don't want to rate people's traumas or compare people's traumas against each other. It's more about, is it having a lasting impact on you? And trauma is not just about what happens to you, it's also about what didn't happen to you. So emotional neglect, a lot of therapists believe, is a trauma because there is for a lot of people, a ongoing need to get these emotional needs met, and they aren't maybe in the most I don't know, general ways that society would accept. And so they get marginalized or stigmatized for seeking emotional support in that way. Not getting, having parents that are good examples, or parents that reject you because of your identity. These things may not be like assaults, but they are the absence of love and belonging and connection. And that is what we humans need to survive. We don't just need food and water and shelter. We need belonging, connection, acceptance, and emotional health. And so we're learning that emotional trauma is equal in terms of symptomology in most cases to physical trauma. And that is a new breakthrough that's only been in the last 20 years that we've been kind of understanding that. And it's only really coming into the practice of therapy in the last 10, to show you how far behind things are. Okay, so that being said, the reason we know about trauma and the effects of it were many reasons, because they started, the scientists and psychologists were studying war survivors. This is like back in the World War I, World War II, and they called it shell shock. That was when we first kind of understood what PTSD was, at the beginnings of it. But in 1995, in San Diego, there was a large study done over multiple years with people and giving this little questionnaire called the Adverse Child Experiences Questionnaire. And you can actually look up this questionnaire and take it yourself, ACE, A-C-E. It focused more on physical and a little bit emotional, but mostly physical bad things happening to you as a child. And they were interviewing a lot of middle class, what I would call normcore folks in San Diego suburbs. And what they noticed was extraordinary. And let me see if it's on the next slide here. Basically, that a lot of people who they didn't realize had experienced these childhood traumas. When they experience these traumas, maybe they don't have PTSD, maybe they just, they don't have post-traumatic stress, but any number of traumas, the more traumas you had correlated on a graph, like in math class, with all sorts of horrible outcomes. If you had substance abuse in the home, if your mother treated you violently, your father, or their parents, even the parents divorcing, incarcerated relatives, mental illness in the family, emotional neglect, physical abuse, emotional abuse, sexual abuse, obviously, even somebody going to jail in your family, any presence predicted higher outcomes of lifelong health issues, not only emotional and mental health issues, but addiction, risky behaviors, and physical things like cardiac issues, more likely to use cigarettes and things like that. So it was incredible for the researchers to find that in this normcore sort of population of Kaiser Permanente in the suburbs of San Diego, that the prevalence of trauma was high. People were coping with it, maybe not as well, but the number of incidents as a child increased negative health outcomes that doctors, physical PCP doctors, were noticing in their clients. And that was a breakthrough for trauma, because we realized that the more things that had happened to you before 18, now it can still happen to you after 18 and still have the same effects, the more likely your long-term health issues were not good. So we have now, as therapists, expanded the definition of trauma, even as the medical community wants to keep it small for various reasons, which we won't get into in this presentation. So Brittany, let's talk about what isn't trauma-informed care.
Absolutely. So what is not trauma-informed care? I think in order to talk about what is not trauma-informed care, we also have to have a little bit of a history lesson of most counseling, psychotherapy, psychology has absolutely been normalized by cishet white men. And I think to this day, a lot of our graduate programs, both in social work and in counseling and psychotherapy, continue to have that kind of mindset of that the techniques and the modalities and the theories were developed in an era that was very patriarchal and very male, conservative, religious based. Because of that, a lot of therapists and social workers are now subtly, unintentionally kind of schooled in a way to think about this ego-based care. there's also this built-in power dynamic, and we know a lot of our systems have that. But there's this idea that there is something wrong with the patient is ill. I like to prefer to use the word client. So the client is ill and the clinician, AKA I, have to fix them. I'm the healthy one. I'm the one that knows how to make you go back to normal, quote, quote, quotes. And it's also a lot of times in our programs and our theories and modalities, some therapists focus on this like logic center, like think your way out of the problem. Let's change your bad thoughts, quote unquote, to good thoughts, quote unquote, and kind of completely neglect that when we have experienced a traumatic event or several traumatic events, that we're actually having a nervous system reaction that has rendered that logic center, that prefrontal cortex, kind of useless or offline. Because in order to survive in those situations, your nervous system needs to make the decision on what to do that completely negates any logical thought. So if you could roll on to that next slide for me, please, Paul.
Absolutely.
So some of the interventions that may have a time and a place for, but are not trauma informed, are things like advice giving or behavioral modification. So like, working out gives me that example a lot of like, oh, so you don't want to smoke cigarettes anymore? Go work out instead. That's kind of like a behavior modification. Confronting someone who is being abusive or neglectful, or maybe, hasn't given you the needs or wants that you have been looking for. So confronting them isn't necessarily trauma informed. Exposure therapy, I think that needs a little disclaimer asterisk of like, there is a time and a place for that. But if you don't have rapport, if you're not learning what the coping skills are, if you're not resourcing available ways for a client to regulate themselves, exposure therapy is going to be doing more damage than good. A lot of cognitive behavioral therapies is that, okay, the way we think impacts our behavior, which is a true statement. But again, if that's the only thing you're focusing on and not how that nervous system is in reaction mode and has noticed that something around our environment or a person is unsafe, that CBT, that cognitive behavioral therapy, is not going to be very beneficial. And then a lot of parents, which also we are fighting the dregs of a lot of stigma, a lot of paradigms, a lot of theories that came out of the 60s, 70s, 80s, and 90s about parenting. Many of that believes that punishment is a way for to change behavior. And what we're learning, depending on punishment, so if we're thinking about corporal punishment, like spanking and things, using intimidation, using scare tactics, that is going to be even more traumatizing to that child and is not a very good behavioral modification stance. So Paul, is there anything you wanted to add to those things?
Yeah, I just want to say to Brittany's thing, there are well-intentioned therapists out there that are doing these things who have not been educated completely on trauma-informed therapy. There are people that think they're trauma-informed and are not. And I think the issue is, if you do these things with understanding the context and the environment, educating the client and giving the client agency, some of them, like a little bit of CBT, could help, right? The issue is that a lot of therapists rely on that and start getting frustrated, especially in West Michigan, the stereotype, when their clients weren't like changing everything, right? It's because this trauma is stored in the body and you've got to work on mind-body. We believe mind-body techniques work better because they acknowledge it. And also the context, the environment, all these things are important, where oftentimes in the old days and still lingering, therapy is done in a vacuum. Oh, these are the bad thoughts. Oh, well, we need to get rid of those. These are the bad behaviors. We need to get rid of those. We're also saying good and bad. So you see, there's a lot here, and we're trying to change the paradigm without being too preachy. And like exposure therapy, is, again, like Brittany said, it could work. Any of these things could work if the therapist is trauma informed. And the problem is, most of the ways that these are taught in graduate schools are not trauma informed. Until maybe recently, some of them are changing, but in general, my experience is not. Oh, yeah. Do we want to go into this? Do we have time? How much time we have?
I was gonna just briefly describe some of these things about what are the themes in these statements. So some of these statements have come from professionals that Paul or I have heard or have had clients report to us. Obviously, all of those are anonymous. And I think the key themes in a lot of these statements is they feel like a microaggression. They are filled with maybe shame or blame, with a client not quote unquote getting it right or not being resilient enough. Um, a lot of these statements don't really address the reasons why a behavior or an episode or a trigger or a response is happening. There a lot of times hospitals, they're addressing the acute concerns and not necessarily the reasons why behind that. And I also think that in the professionals that are maybe saying these things are not continuing their own education. They haven't done their personal work. They haven't had enough consultation or sought out CEUs to get some of these trauma-informed care. Hopefully, by the time that we have heard these things or clients have reported these things, that by that point, we're really hoping that these clinicians have had some more education and have really looked at their implicit biases and the ways that some of these, even well-intentioned, had a different impact on those clients.
Absolutely. I agree completely. And just for time's sake,
this will be our last bit, Paul.
Okay, I'm just trying to make if we have 10 minutes or 5 minutes. I'm not sure.
I'm going to say about 5-ish minutes. This is our last bit.
Okay, cool.
So what is actually trauma-informed care? We've talked about what is not trauma-informed care, and I'm going to let Paul take this part over since I just talked a little bit from that last slide.
Yeah, so trauma-informed care is a broad range of things that is an umbrella that sort of goes over lots of different therapy interventions, including trauma-specific modalities. If you want to learn more about trauma-specific modalities and trauma-informed care, and this presentation is not enough, if you go to Trauma-Informed Counseling Center of Grand Rapids, just Google that. It'll go to our main page, or Health for Life Counseling, and go to the trauma-informed page. We have almost a 40-page frequently asked questions about trauma on that page that I've written with other people's help. So you can read all of that and see what trauma-specific interventions are. But for the sake of this presentation, basically, a trauma-informed approach is delivery of behavioral health care that understands trauma. That's a huge thing, which a lot of therapists haven't fully understood that. They only think of it as post-traumatic stress disorder. They don't think about the body involved. They're only isolating the head, the mind. That is not, trauma-informed is a full body situation. And not just full body, it's family, it's context, it's environment, it's cultural context, it's everything you lived through, it's where you grew up, it's where you were educated, and all of those things inform how we view ourselves, right? And all those things inform how we feel about ourselves. And all of the events you've gone through make up how you act, unless you've done a lot of work. Most people are coming into therapy raw. Basically, they are believing negative things about themselves. They have all these physical reactions. They don't know where they're coming from. We want to see the awareness it has across services and populations. People have medical trauma, sanctuary trauma. People go to the church. People go to different groups. They try to find shelter. They try to find belonging. They try to find answers to healthcare, and they get traumatized there too because of the way people talk to them or treat them. It involves viewing it through a cultural and ecological lens. Context is a significant role in how people perceive and process traumatic events, whether acute or chronic, meaning whether long-term or short-term. And some people go through a bad event like a car accident, and they have trauma in their body, but because of their background and belief system and upbringing, they might not fully manifest symptoms, right? That's something we need to remember as well. Trauma-informed care involves vigilance as a health care practitioner in anticipating and avoiding institutional processes and practices that are likely to re-traumatize individuals. That means a lot of really listening to them up front, from the front desk person. We want to train our front desk person, our administrators, to be trauma-informed, to not ask ridiculously stigmatizing questions, to have, all of the different genders on your forms, different things like that, to not re-traumatize people that are coming in for help. Okay, basically, trauma-informed care recognizes human adaptation, We're constantly adapting to our environment. We're constantly adapting to positive and negative things that occur to us and other things that are maybe benign. Our nervous system, in the most summarizing way I can put it, when it reacts to trauma, we go into reactions such as fight, flight, freeze, fawn, which is trying to people please, and collapse, which is basically giving up, and depression. You've probably heard of some of this in school. There's also another one I'm adding. It's called fracture. Fracture is not on this slide, but fracture is when we believe people dissociate from reality or dissociate from what's happening and can't accept it, which can lead to more symptoms. Let's see. Yes, a lot of times people don't even realize that they have trauma, or that the trauma is the basis for their anxiety, or the trauma is the basis for their relationship issues, or the trauma is the basis or the root of the depression. They don't realize it until much later, because that's how the body works, which is a whole nother lesson. I think I want to make sure, Brittany, we get into the LGBTQIA stuff as well on the notes. I'm not sure if we want to go in here first, but basically that you can read about these on our website. But essentially, we're trying to educate people about why the symptoms are there, because the medical model says you have depression, you have PTSD, you have anxiety, you are messed up, you have a mental disorder. The DSM-5s, the Diagnostic and Statistical Manual for Mental Disorders, which means that they have some sort of standard of normal, and that in and of itself is a problem. However, as practitioners, we do have to play both sides of the fence, meaning we are in the Western medical model. That is where we live. We can't, this is the capitalist system we live under. We must understand how the medical community views of mental illnesses, but we have to be able to educate the consumer about why these things happen, why they feel this way, and that these are not permanent conditions. Okay? These are not permanent conditions. I came down with depression. It could be biological, ecological, traumatic driven. It could be genetic, runs in your family. It could be a diet issue. It could be an allergy issue. It could be, there's so many systems that can cause mental troubles, right? And we want people to know they're on a spectrum, and they're also something people can recover from, right? Therapy is the answer for a lot of people, but also there's a lot of other modalities that can help as well. Trauma-informed, you can sort of see here, we're trying to create a safe environment. And I'm going to turn it over to Brittany here in a minute.
So I'm going to have you keep that slide up just as I'm talking about this last few things, Paul.
Sure.
Or not that one, the other one,
The other
7 through, yeah. Just so people can read that. So one of the questions we get at Health for Life is, how is our office working to rebuild trust in our LGBTQ plus community members? Because we know that our systems, medical professionals, other clinicians who have not been trauma informed has really impacted and injured, I would say, emotionally, mentally, a lot of our queer community members. So some of the things that we're doing is Paul founded this clinic on diversity and with affirmation in mind. He has been very careful and has done a lot of vetting on who Paul hires and who he's working with. There have been people that have not made it to a second interview or have been let go if they do not have those values in mind of diversity, of inclusion, of affirmation in mind. Health for Life and Paul have been really adamant about the clinicians that work at Health for Life being very empathetic and caring people, and to seek education, consultation, having conversations to confront those biases. We have an active diversity statement, but beyond that, we encourage the staff here at Health for Life to participate in things like the Pride Festival and so on. And then Paul has been also very gracious on, if there is a need, he helps clinicians find a way to reach that need. And so an example that we talked about earlier is that I have made lots of programs with relationship groupings in mind to kind of fill the need of premarital counseling for LGBTQ plus folks. Yes, there's a lot of stuff in that. There's a big community here for our non-monogamous folks, so having therapy for them. So those are some of the ways that we have we're trying to rebuild trust in our LGBTQ community. Is there anything you wanted to add to that, Paul?
Well, just that we as a counseling clinic believe in learning from each other, which we do often. We have supervision groups in that, but we really believe in learning from experts. So one of the things our clinic does, and this is not something that is like required by the state or required by anything really, but we bring a lot of outside teachers in. We bring in professors, we bring in experienced clinicians from all over the country via Zoom to teach us every month. Maybe we do about 2 or 3 a month, different things, so our clinicians can keep growing outside of the status quo continuing education. If anybody's ever been in continuing education, sometimes it can be quite dry and boring. We obviously still do our continuing education, but we're bringing in outside because we want to be aware of those biases, and we don't have, like, we affiliate to be as neutral as possible. What I mean by that is we want to be welcoming everybody, and also socioeconomically. So we are one of the few group counseling practices, maybe one of the only ones that is not a nonprofit that actually takes and accepts Medicaid as well as private insurance. And we have sliding scales because we have interns who will do very low cost counseling to help people. So we're trying to put our practices in play and not just signal that we are diverse and trying to do this. We're trying to put it into action with actually helping some of the difficult, the people that are really suffering, which means, low SES, low socioeconomic status in a way in the United States is another form of violence, keeping people poor, keeping them in the system, of not being able to be very mobile. So we believe that that is also affecting LGBTQIA folks and others as well, marginalized communities. So we're trying to invite them in as well. So I would just say we're doing our best. We're open to feedback. And we are, as I said, we are trying to put our actions into place and not just make statements. Like we are trying to live it, and we try to keep our staff that way. We are not just bringing any therapist in with a license. We're highly vetting them and their performance.
And I'm just going to add to that before we close this presentation portion out, Paul, is that if there is a client that did have an issue or maybe felt like there was a microaggression or there wasn't trauma informed, that they have the ability to speak with our admin staff, they have the ability to speak with you, and they have the ability to speak with Ashley, which is one of our admins at Health for Life. They can also make a complaint to whatever licensing board that person has. So whether it's a therapist going through Laura, ACA, I don't know what the social work one is, but they also have the ability to make a complaint there.
Yeah, we support that completely. Okay, so are we going to Q&A next? Is that what's up?
Yep. So this is just our last slide. I thought it was a wonderful quote by Vessel van der Kolk about trauma. But yeah, we're going to be opening it up to Q&A or questions or comments.
Yeah, I'll leave the slide up for a second and then I'll hit stop share so people can see us better. But feel free to, I believe Riley and Cameron will be monitoring the chat. So questions, ask away. I'll just start talking. Let's see what else. One of the things we were reading about was that LGBTQIA+ teenagers are over 4 more times likely to commit suicide than cis hetero counterparts. 1 in 3 LGBTQ+ adults experience mental illness compared to 1 in 5 of the general population. According to a study in 2013, many polyamorous individuals avoid seeking professional help because they are afraid of experiencing stigmatization, bias, and misunderstanding of their lifestyle choices from a mental health provider. Finally, this is like becoming a mainstream statistic that we've seen, but African American women are more likely to be dying or misdiagnosed with preeclampsia and pregnancy issues. So that's something we want to keep in mind as well. Racial trauma. Okay, go ahead.
Yeah, we just had a question in the chat about racial trauma. If you'd like to speak a little bit about that.
Yeah, absolutely. I mean, this is the LGBTQI plus consortium, so we weren't really touching on that as much, but that is a huge emphasis for us as well. We do our best to hire a diverse group of therapists, and we have a pretty diverse group that currently. But I would just say that being trauma informed means you have to be basically anti-racist. You have to understand what racism is. You have to understand the context of racism. You need to understand that the United States as a current country was built on racist principles. You have to understand that we like basically white folks have privilege. White privilege is a thing. So essentially we have trainings right now. We have a DEI training going, a diversity, equity, inclusion doctorate person teaching our clinic that. And so I'm not sure what the question is other than, do we understand about racial trauma? Is that part of trauma-informed care? Absolutely. That's where cultural context comes into play. So when Brittany talked about cultural context and social stigmas, we know that, I don't have the stat in front of me, I'm on my iPad over here, but the African-American community, for instance, is much less likely to even go to counseling because of the issues they have felt were targeted towards them by mental health practitioners. Same with the Latino community as well. There are stats on that. So we are very, I guess, informed about that. And we make it a big emphasis to invite people and make them feel safe in our center. But I don't really see a direct question other than
I'm gonna add to that, Paul.
Yeah, go ahead.
I think that as both you and I, and we've talked about this, since both you and I are white clinicians, of asking what a particular clients, if they are BIPOC, what their experiences have been, how has racism or any of the other isms in equity have impacted them? What's it like talking about these things in front of a white therapist who has been socialized and normalized to have that privilege? I don't think that therapists that are not willing to have those questions, I don't know if I would say, this is, I guess, my opinion, I would say that they are not going to be trauma informed if they're not willing to have those uncomfortable conversations. And then the asterisk disclaimer star there is that is the individual experience. So recognizing that one person who is African American, who is telling their experience and how racism has impacted them, doesn't mean that is 100% the way that it has been for all people in that community. And two, that as a therapist, we want to know their individualized experience and how those traumas of racism has impacted them. But then it is absolutely the responsibility of that white therapist to do their own work, to take those implicit bias trainings, to do those DEI trainings, to get books, to listen to podcasts, of having those really hard conversations. And I think white people need to be calling out other white people when they do something that is not appropriate. And I know you and I, Paul, have definitely done that for each other as well. I'm hoping that answers that question a little bit more.
Yeah, absolutely. I'd love more questions. One of the things I would say is, if you're looking for resources, is we all have implicit bias. It doesn't matter where you were born, you have it. Check out the Harvard Implicit Association Test. A lot of our clinicians are taking that for part of our discussion. And yes, we do not want to make assumptions ever about a client. So we are going to learn about their culture. And if there's something we don't understand about their culture in particular, we are going to do the research on that. When a clinician believes a client should be referred out for specialization such as EMDR, how would you prepare a client for that? Okay, so I'm going to address that real quick with our clinic. First of all, we have about 17 people trained in EMDR therapy. That was one of the big emphasis that we have at our clinic. So a lot of people that are coming to our clinic, if they are not seeing an EMDR clinician, we have those in-house. But if a client believes a clinician should be referred out, such as EMDR, how would I prepare a client for that? I would have a number of discussions with the client from a trauma-informed angle to discuss why I think that may be helping them better than talk therapy. In my mind, talk therapy is very effective, and you can look at the stats on that. However, EMDR has not really been studied in the way I think it should be, because the results of EMDR are phenomenal. Like it's upwards of 90%. Talk therapy is upwards of 72% of efficacy rate in terms of asking clients. And if you look up Bruce Wampold's book, he did 10,000 meta-analyses of studies that involved 100 to 1,000 participants, and therapy's efficacy rate is phenomenal. EMDR, in my mind, is another thing on top of therapy. So how would I prepare them? I mean, a lot of empathetic conversations, discussing what is best. Therapy should always be in the best interest of the client, not the therapist. We should never, ever have a client in our caseload for our convenience because we like working with them because it's easy for us. And if we feel that our edge is that, shoot, I don't know how to help them with this trauma, then the best and most empathetic thing to do is to refer them to EMDR. Now, one thing you can do as a therapist that sometimes is frowned upon in the old literature is, I would say, ask the client, do you still want to see me once a month or check in every couple of months with the talk therapy? Because that relationship is so important to that client. I don't want to just dump them off and say, you can't come see me again. So if they want to see an EMDR therapist 3 times a month and you once a month as the talk therapist, I think that may be the most ethical thing to do. Have them go through the EMDR. And if once they get through that, they could come back to you. That's another option as well, because that relationship is important. We don't want to be territorial with our clients. We always want the client to get the best care. And that means we don't remove their relationship. Pet peeve, DBT programs say you have to give up your other therapist. I'm 100% against that. I think that's completely ridiculous. You can go through the DBT program. You don't have to sever the relationship with the therapist. Maybe you don't see them every week because of insurance issues. That's fine. Maybe you only see them once in a while to check in, but that relationship is important, and it's not trauma informed to sever relationships based on only clinical reasoning. Look up the ethics on that. So what I would say is, I went off on a tangent, but you do it with education, you do it with care, you do it with compassion. You don't do it in one session. You take your time, you evaluate how it's working. You could have the client fill out SRS or ORS forms, which are session rating scales or outcome rating scales. You can get those for free at the Feedback Informed Treatment. If you Google Feedback Informed Treatment, I have a lot of our clinicians using these forms, which means that the clients get to tell you on a rating scale how they're feeling about each session. So you're not just assuming, oh, I'm a good therapist, they look happy. Some clients won't tell you that they felt upset or that they felt used a microaggression. They felt that you assumed something. But if you give them a rating scale and you say, this is for my development, and you give them that after session, and they can write down how they felt about it, and then you will take that into consideration instead of shaming or blaming them for not liking what you did. That's a good way to track it. So if you take somebody, they go to EMDR, maybe you don't see them for a while, have them rate their symptoms, have them rate the sessions. How are those going? Do they feel safe there? And then you can be that emotional support. Now, if you do have to sever completely because of their insurance reasons, allow them to contact you to come back, an email or a phone call at some point. Hopefully that answers your question. Well, goodness. I would say as an EMDR practitioner, she's asking what type of coping or emotional regulation skills are necessary to transition to a client into EMDR so they could do the work successfully. I'd love to hear what you're looking for. Okay, well, I would say this. For me, EMDR phase 2 could last 6 months to a year. And I think in the EMDR manual,
Can you educate what EMDR phase 2
yes,
for people
sorry,
that know what EMDR is?
Sorry, EMDR phase 2 in the manual is about creating a safe space for clients and learning how they can regulate their emotions, essentially. And a lot of EMDR practitioners, I would recommend, if you haven't, go to advanced EMDR trainings. Join EMDR International Association. Go to some advanced trainings. Go to the conference, because it's going to teach you. Actually, we just have we had a new training I just downloaded and bought for our team, which is, and I can't remember the name of it, but it was basically like cultural bias and cultural competency in EMDR, and it's all BIPOC. It's one white guy and a bunch of BIPOC practitioners for 6 hours teaching about how to implement EMDR appropriately in different cultural contexts. Very good training. You can Google it. We have it in our personal training 25 gigabyte drive or whatever it is, terabyte we have going on. But EMDR phase 2 is about the emotional regulation coping skills. And I would say it just varies by client. For some clients, they actually need to go through a whole round of DBT before they can tolerate EMDR. For other clients, they may be able to learn mindfulness meditation. For other clients, they may be able to learn visualizations. For other clients, they have to have a whole book of coping skills. So I'm not sure how to answer that in a simple way because it's
Can
case
I
by
try
case.
to can I try
Brittany,
to
go for
answer
it.
that?
Yes.
So I used to be just a talk therapist before I got EMDR trained. And so one of the things that when my client was like, I think I need EMDR therapy, is what I was helping them with, which I guess would be phase 2 in talk therapy without the EMDR lens, is I wanted to make sure that they were using their coping skills, the community, and their resources. And so like if they reported back like, oh man, I really got stressed out in this test, and maybe an unhealthy coping skill was like they binged ate all of the food in the fridge, and then they were doing these horrible quotes horrible things to then go to, oh, I'm able to now take a step back and breathe. Oh, I am able to stretch. Oh, I was able to call my mom and be like, Mom, I just really bombed this test and I'm stressing out about it. Like if they are able to effectively and consistently use their coping skills, community, and other resources, those I believe are a good candidate for EMDR. And now as an EMDR therapist, one of the things I ask clients is that talk therapy, even though it is very good at what it does, it's a little bit of a slower process. And EMDR, once we're really working on phase 4, which is the actual reprocessing, both side stimulation or bilateral stimulation, some of those effects that come out of EMDR is sometimes that you get more fatigued, or you feel more connected to your emotions and might feel tearful or weepy, or you might feel a little bit more restless or agitated. These are some of the things that happen sometimes out of EMDR, and not for everybody, but I think having all of that education for that client to make the best decision on what's right for them is really good. And I know I have suggested, after maybe working with a client for 1.5 to 2 years, and there's like this one part that we just keep getting stuck on, that might be a conversation of like, I think this part needs some EMDR. We can still do our talk therapy, we can still do our art therapy or whatever modalities that we're using, but this particular memory, this particular trigger would be really good for EMDR. And I'm hoping that answers your question a little bit better.
Yes, and sorry I didn't explain. EMDR phase 2 is where you're working on those coping skills, and I want to just make sure that when I said it could last 6 months, what I mean by that is I may keep somebody in that phase using EMDR theory and paradigm, but I don't know if they're ready to reprocess the worst trauma of their life. And so I won't bring them to phase 3 and 4 until I'm sure of it. There's ways in advanced trainings to do little tests where you could like do like a mini session of EMDR, see if they're able to tolerate it. If they're not, definitely don't go further. More questions?
I just wanted to pop in and say, like, thank you just for going on your tangents and everything that you have to share. It's very informational. We do have about 8 minutes left, just so you're aware of that.
Yeah.
And I'm
so probably a time for one question left.
Yeah, there's lots of folks on here, so I know it's lunchtime. I'm just going to say in the gap while we're waiting for a question, at our website, we have a ton of articles and blogs on trauma. My podcast is called the Intentional Clinician Podcast. Brittany's been a guest. We have multiple, I would say at least 7 or 8 episodes on trauma that you can listen to. Also have some lectures on trauma on the YouTube page that's associated with the Intentional Clinician Podcast. On the Trauma Informed Counseling Center of Grand Rapids page, where we talk about our trauma-specific modalities. As I said, there's over 40 pages of Q&A that you can check out as well.
Can you remind us where to go for that?
Yes. Yeah, Brittany put our main page in there. That's a little bit of the marketing stuff, but if you go here I'm going to share this actually, since that way you'll have a visual. I'm a visual person. So this is our sub page, because this is the second name of our clinic. Our main name is Health for Life Counseling. That's just because it's easy and brief. People remember that. And we like the name because we believe we want to equip people to be healthy for life and not just dependent on therapy. Okay. We want to get them out there, living their life, dancing in the moonlight, having a great time. Okay. Sorry, that was a little ableist, or doing fun stuff. Okay. Whatever that is. Here's our little page here. And if you look here, these are trauma specific modalities. Not all of them are 100%, but they are. And this is our exposure response prevention therapy, which is a new type of exposure therapy, which you have to be specially trained in, and it is trauma informed. So you check that out. Here we have the frequently asked questions. This is what I was talking about. We have literally all of these questions. I don't know, this could be like 100 pages. I don't even know. Some people think that the word trauma is overused. We have the whole thing on that. What's the difference between trauma and difficulties? What is nervous system informed therapy, which I think should be the new name of it. So just checking this out, there's a lot of information there. If you go to the blog, we have almost 400 blogs. So these are all articles we've written. And if you can sort of sort them, they aren't perfectly sorted, but here are some of the trauma blogs we've written. Let's see, but
and it is we that, Paul has asked us or friends or colleagues that he knows to add to this blog. So I very much want to say there is a,
yes. It's a group effort, right? And here is the podcast, and that's even a group effort. You can see all of the different blogs. Now, the podcast is more of my opinions, so like, don't take that as the clinic's opinions, but we have plenty of different guests, different people, and we do have some on, actually, the Black Lives Matter. I have podcasts on that as well. Is there anything that LGBT people experience specifically when it comes to trauma?
I'll answer this one.
Brittany.
What I see most when I am working with LGBTQ plus folks is church hurt, sanctuary trauma, religious trauma, particularly coming out of the Grand Rapids area. I didn't see that nearly as much in other places that I have lived. I also boundary crossing and domestic violence. And I notice, and I think this has to do with our internalized biases and stigma on patriarchy and gender norms. But I notice a lot in queer relationships that it's more challenging or difficult for them to identify domestic violence or toxic relationship habits. And then the other thing that I see a lot is that a lot of questions just about sex, sexuality, STDs, STIs, those types of things that they haven't gotten information from other places or were too scared to get that information. But those are the three things that I see most working with queer folks.
And I would like to add to that. My additional piece is what I would call, obviously, family trauma. But what I've seen even worse now, because LGBTQ rights have advanced, is that there are family members who are straight up microaggressive and subtly discriminatory towards the people in the community. And so it's harder to identify those, especially in the last 10 years, is that somebody might say, oh, I support you, and I'm glad you're, that this is your identity, you were born this way, whatever. They support you, but they really don't. And so a lot of people come in and they feel confused about family relationships as well. So that's a big one I've seen. In addition, obviously, medical, going to the doctor, going to the clinic, going to the hospital all the time, school issues, just to add to Brittany's stuff. It's everywhere. It possibly is similar trauma than other people face, but it's magnetized, and it's even worse because it's like a double trauma. You already have difficulties at school with bullies. Okay, now you have difficulties at school with bullies because of your identity. Like, it's a double whammy, in my opinion.
And I would say identity, like having that intersectional lens. My partner is a mixed Black and white person and is queer, but looks very masculine. So then you talk about the microaggressions and the bullying and not only racism, but like homophobia. There's a lot of that. But I see
Mhm.
we only have like a minute left. So thank you so much for having us today. Riley, if people continue to have questions or anything, is there a process that we can have to make sure that these people get the answers that they need or want?
Yeah, so I'll actually have Cameron close us out, but I'll be sending out an email with the information that was kind of covered. Um, so if anyone has any questions, just be sure to respond to that email. But if you guys are both done, I'm gonna pass it over to Cameron to have him close us out.
Yes, so thank you so much, Brittany and Paul, for your time sharing this service. We appreciate how your office is working towards being safe and affirming to LGBT plus community members. Again, I would like to remind everyone that our Give Butter campaign, about our Give Butter campaign, please feel no obligation to give, but if you would like to, we thank you so much for your contribution. You'll be receiving a follow-up email soon after the webinar about this information and links to this information. If you are receiving continuing education credits for this webinar, this information will also be in that email. I want to remind everyone again that this session today was recorded. It will be uploaded on our website next week. Next session date will be May 23rd at 1 o'clock, and the topic will be about gender affirming hysterectomies. If you're interested, please register on our website, and if you and feel free to spread the word. Thank you everyone for attending.
Thank you.
Thank you, everybody. Appreciate it.
Thank you.
Thank you.